Yeah.
Sure, but not yet. Can't start yet. Oh, so did you guys get my email about ExamSoft?
That's the best part. Decided when you know something. That's the best part when you have to sign in and you like have to look for the new information. Some teachers, some teachers don't really sit on Blackboard first, so then you have to like sign into it yourself. Your grade. And it's hard. But then you're like, I don't remember, I passed there.
Oh shoot. So can we do this?
Okay, guys. So there's a few.
We can't look at the example. We can
questions
look
that
at
I
our
threw
score.
out.
Oh, I
It's gonna
see.
seem weird because it kind of shook up the point system. Actually, I want to say two questions I actually threw, and then two or three others I gave everybody credit for. So that's the difference where if I throw a question, it makes it out of, instead of 50 questions, it makes it out of 48. So that's why the percentages look a little weird. It's not just like an 82. It's like 81 point or something, okay? And it's because of the throwing. And because it does all of the computing, thank God, for me. So, and then there's one question that I gave, the answer, I think was like B or D. It was osteopenia or osteoporosis for the loss in bone mass. So if you put either one of those, you got credit. And Kate, I don't think that I have actually graded your, or I haven't posted yours yet.
Okay.
And then I figured out why you couldn't get on.
Excellent.
Yeah, so it'll be fine.
Yes.
Okay, so what I'm going to do, and this is what we'll go through. We don't have to spend like a huge amount of time on it, but it's sometimes it's helpful. I don't know if you can even see it though. Can you even see that?
Yep.
Sorta? Yeah? Good eyeballs? Okay. Okay. So, I'm just going to go through. So, the Samaji effect, overnight hypoglycemia with rebound hyperglycemia in the morning. A lot of these questions, you guys all hit them. Boom, 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 boom. Okay? The questions that I actually removed were, I think, like actually question 49 and 50 in my version, because yours were all randomized, right? It was the questions about, what was it, like the somatic pain theory and something else. I just gave everybody points for those two. There was one, reaction, oxidative species, blah, blah, blah. Okay, yeah, so I just got rid of those. Because I've had those questions in there, but then we talk about it actually in another place within the course, so it was kind of like, oh yeah, you guys I didn't really give you that. And like, even though we talked about, like the elderly, there was a question about thyroid stimulating hormone, right? Is it increased TSH or decreased? And even though some people picked the correct answer, we don't go over hormones until the very end. So it used to be that we went over it prior to this content. So, so I gave everybody points for that one too. Thought, good job. Okay. So I'm just going to kind of go through if you have questions. So Bobby's dad is more likely simple sugars. So it'd be kind of like if I wanted to have chips and some pretzels and a soda, just a bunch of simple carbs, right? How could I offset that? Vegetables, have some cheese with my crackers and my wine or something, you know? So it's like throwing a little bit of protein in there, throw a little bit of fat in there, and then you kind of completely change the complexity of what you eat. Vegetable, you know, broccoli, whatever. Yeah. All that healthy stuff. Visual impairment may develop in people with diabetes because of all of the following except. So everybody actually got this right. Who even knows what exophthalmos is? I love it. Even if you're like, I have no idea, but I knew I didn't know what it was, and it didn't sound right. Exophthalmos is actually that bulging of the eyes with hyperthyroidism. It's like where they look like, why are you so scared or staring at me? Like really, really big, bulgy eyes. Okay? So, yeah. But everybody got it right, so good job. Don't know what that is, that's what I'm picking. The mechanism for the development of the dawn phenomena is related to what? And it's the release of hormones. Pretty much everybody got that right. After Bobby, age 12, was diagnosed with type 1, his father John went in for a physical and was diagnosed with type 2. What led the practitioner to believe that he had type 2? Well, his glucose was high. So John with type 2, would he have been producing some insulin? Yeah, but is that the first thing that we check? No, okay. He was having headaches. Random, right? Okay. So if you check somebody's sugar and it's like, 180s, 200s, then you go, I wonder what it has been over time. And that's when you start going down that path. Child asks you if he will outgrow his type 1 diabetes and be cured. You tell him, nope. And everybody got that right. Well, you say it nicer than that. What would you expect to find in the individual with type 1 diabetes? And this is an elevated blood glucose level. Not insulin, not all of these, and white blood cell count only if they have an infection, right? Early signs and symptoms that you would expect a person with type 1 to exhibit include, I think everybody got this right? The excessive thirst, hunger, excessive peeing, weight loss, fatigue. What blood test depicts hemoglobin and red blood cell exposure to glucose? Everybody got this right. Correct? You all got it right? Yeah. That's what I thought. The pathophysiology of type 1 diabetes can be best described as destruction of the pancreatic islet cells which produce insulin. Okay, has nothing to do with your hypothalamus. What is resistance of insulin-sensitive tissues to insulin? Type 2. Thank you very much. Okay. 12-year-old admitted with type 1 diabetes. In order for his diagnosis to have been made, Bobby had all of the following pathophysiologic characteristics except. Does Bobby necessarily have an enlarged pancreas? This is kind of saying he would have these signs and symptoms. If anything, if your body is not producing a hormone and those particular cells are not doing their job, what do you think they do? Atrophy. So would you have an enlarged pancreas? No. Bingo. Okay. So enlarged pancreas is not correct. This one I actually threw what's not on the ABC algorithm, and I'm like, yeah, we didn't really talk about this, although I wonder where you could have read it in your book, or I don't know, looked, or I don't know. And then I thought, well, okay, interestingly enough, hypoglycemia control is not on the algorithm. And I thought, well, I didn't even really mention that, so I can't remember if I just gave you all credit or threw it, I can't remember which. But you do foot care and blood pressure control and eye exams and all these because you're trying to watch for chronic complications, and they call it just the ABCs. There's like a list of things, and hypoglycemia control, surprisingly, is not on there because it's not a chronic complication. Okay, it's more of a commonality. You just know that you're going to do that. So anyway, I was like, yeah, we didn't even really talk about that, so that was a little unfair. What was the 3 most common signs of diabetes? The 3 P's. Even if you didn't remember the words, there's only 3 there that have P's. Okay? So you should have been able to get that. Which of the following describes the goal of the aging process? quality of life, right? Okay. Aging creams and facelifts, right? Girl, you better fix them wrinkles. What's the treatment of Alzheimer's? Supportive care. Electroshock therapy. I don't think anybody picked it, but I'm going to go back and look. This one, how is osteoporosis prevented? And this was weight-bearing exercises. We talked about that. It has less to do with your calcium and vitamin D than anything else. Treatment for Parkinson's. So some people increase the stored levels of dopamine. Well, you kind of can't because you don't produce the dopamine, so you can't increase the stored levels. Now that would be super great, but you can't because it's just not there. So you have to balance inhibitory and excitatory. So this is where the acetylcholine comes in, as well as the levodopa. So you're trying to balance the two. All the following are examples of the 4 primary manifestations of Parkinson's. So postural stability. Yeah, that was an easy one. Which is not a risk factor for osteoporosis. Increase in bone mass. I'm telling you, people will go, oh, bone, and that's what they'll pick because of just simply not reading increase, decrease. Or it's a matter of just simply reading the words. Following types of fractures common due to the high content of calcaneus bone, and this is the hip, right? You know, you always want to tell an old person in the hospital, you're going to fall and break your hip. And then the second most common is the wrist, because they fall to catch themselves. Which of the following factors contributes to primary osteoporosis in women? So primary was all about the estrogen. Secondary had to do with bone loss and C and D and all of your other your vitamins. Women's bones are weaker than men's. Okay. Elimination changes common in the elderly. So urinary retention, not usually a problem, right? It would have been the opposite. It would have been incontinence. Renal function impairment and aging is related to, we have a problem with our renin and aldosterone, so it's kind of a hormone thing. You don't have anything increased or enhanced when you get older, okay? Let's just say that, yes.
Real quick question on that, when you're using the word enhanced, because I was using on a few others, you enhanced mean as in made, what do you mean by enhanced? What do you mean?
It's better. If I give you steroids, you are like enhanced. Physically, maybe not emotionally. Versus if I said degradation. Degradation
Every time he talks, I'm just
kind of
like,
implies it's getting worse. So a lot of these terms,
oh yeah, right.
you know, people would use, and it's just like kind of like it's like taking the GRE, right? I don't even know what this word means, and you want to kind of guesstimate if you're not really sure.
Okay, I wasn't sure, because I thought it was
Well, amplified, that's really good too. So like, how could I enhance the proximal tubule function? Well, I don't even know, but some kind of drug or something. Enhance it. You're right on the money. You just have to think of what other synonym could that be. Come back. Okay, alterations in temperature regulation may occur because we have a decreased number of size and activity of sweat glands. Here's another, enhanced.
Yeah, this is the one that drew my question.
Yeah. Well, if they're all enhanced and that one is decreased, what does that tell you? You're getting old, you shrivel, and you die, right? Okay.
I just wanted to make sure.
So here's the one, typical age-related change in thyroid function. So, and we'll get more into this when we talk about hormones. Basically, your thyroid gland is going to ramp up and go more TSH, more thyroid stimulating hormone, so I can produce more T3 and T4. Well, guess what? That you have some shrinkage, so initially you might have that, but over time, you'll get your hypothalamus saying, thyroid gland, what's wrong with you? I need more T3 and T4. So your hypothalamus is gonna go from the anterior pituitary, thyroid stimulate, 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 stimulate. And this gland here is kind of atrophying and it's going, I can't, I can't, I can't. So you see increased levels of a stimulating hormone without any actual production of the hormone. Same thing like with the ovaries, they produce estrogen, right? You could have your hypothalamus telling your pituitary to secrete gonadotropin and all of these hormones, but you're not going to get it because your ovaries just are shriveling. They do, your eggs dry up. Okay, which of the following electrolyte abnormality is not common in the elderly? Do we have enhanced intestinal absorption? No, we do not. That doesn't even sound right. Everything else is decreased. See, so it's not that I'm trying to be tricky, but you know, sometimes it can be something as silly as one word that you may not look at, but you read everything else but that very first word. And you read that and you said, oh yeah, that's gotta be it. So, just saying. Typical pulmonary changes, and a couple people were wondering about that increased ventilator capacity. It's actually like the being able to actually take a big breath is not increased. Because remember, you have muscle atrophy, you have decreased bone density, you have kyphosis, right? So when you're like this, you go, you don't go and expand, okay? So that's why that would be the except. Condition characterized by enzyme activity leads to crystallization, deposit, and calcification of cartilage. That was the chondrocalcinosis. I think everybody got that right. Example of age-related reduction of skeletal bone mass is known as, this is the one I gave credit for both, plaques and neurofibratory questioned and I didn't really talk about it, I realized that I personally think it's unfair because I know there's so much information. And I used to hate that about my instructors when they would just go, well, yeah, it's right here on page 438 at the very bottom. Like one sentence out of the whole chapter is where you focused, and I just don't think that's right. I want you to have a general understanding. So when I decided I threw out 2 questions, so it changed the number, so it was out of 48 now. Giving the extra, just giving everybody credit for it kept that, the denominator 48, but then I just, in the grand scheme of things, do you really need to know this? That's kind of how I look at it. I go, nobody's going to ask you this other than me. Nobody's going to care. Which theory of aging do you choose? You're going to go, they're old, okay? They're old. That's the bottom line. So I would rather you guys know generals and understand how to be able to cross the line between your classes. Like, we're learning about this, so how can I make this class make sense for the others? That's just kind of how I feel about it. So I have this is in that section 2 for exam 2. And it was like your little AMP reminder. You can quiz yourself. You can print this off. It's a little quiz. Do you know where your trachea is? Would you call that your trachea or your esophagus if we're talking about ventilation? See what I'm saying? Okay, I only see one tube there. However, we're talking about ventilation. And then the other one is because what I'm going to hit pretty hard is, remember how, well, I know not all of you had me for Patho 1, but I said that we have respiration, which is the act of exchanging oxygen and CO2, and it happens in 2 places. We do it in the alveoli. Everybody take a big breath in, and take a breath out. Okay, what we all just did was exchanged oxygen and CO2 at the alveoli, okay? But what is happening at the same time is, imagine in your big toe, oxygen is crossing over to the cell in your big toe, and CO2 is being removed from the oxygen in your big toe at the capillary bed. So the capillary bed, remember the venous side is supposed to pick up the CO2 and take it back to the lungs. So we actually do respiration in 2 places, here and then at the cellular level, okay? So what you really need to be reminded of, because we're going to talk about when things go bad, right? When things are really, really wrong. What would you imagine? So here's the capillary lumen. Here's a red blood cell. A red blood cell is coming to bring CO2 back and put it back into the lungs, right? So how do I get rid of it? There, just got rid of some CO2, okay? So we have this epithelial, we have this membrane that we actually have to cross over. In order to get it out of the lungs, we have to get it into the blood so it can attach to a red blood cell. So it's there's a lot of things that go on right here with this little 0.2 to 0.6 micrometers. I mean, it's like microscopic level of membrane here, okay? But if you don't understand this, we have surfactant. What's surfactant? What's the big deal about that?
Keeps it from sticking.
Keeps your that our lungs just don't collapse on themselves is because of atmospheric pressure. So we have just enough atmospheric pressure, so every time I go, and my little grapes, my alveoli, my grapes, go, and then how is it that whenever I go, that they don't go and squish together? Part of it is surfactant, and it keeps things kind of loose. The other part is a little bit of what they call PEEP, positive end expiratory pressure. It's a PEEP. And we have what's called an auto PEEP. And it's because of our atmospheric pressure, there's just enough pressure to keep those little air sacs open, okay? So if something goes wrong with my atmosphere, Is there potential for me to have problems here? If something goes wrong with my surfactant and I don't have enough of that surfactant to help maintain the shape of my alveoli, could something happen? Okay. We're going to talk a lot about different instances and like some specific terms and what they're called. But you guys really have to know, if I poured water into your lungs, collectively, I'm not going to pick on one person, collectively I drown you, okay? I fill up this area, these little sacs, I fill those up with water. Are you going to get oxygen through? Well, the oxygen is in the water and it's going to break off and... No. What it would take would be like, who was the guy that split the Red Sea? Moses? That guy? Imagine, I watched that. Have you seen Exodus and Kings or whatever it was called? Saw it in the movie theater. It was excellent. So that is what I envision. If I had a bunch of water in my lungs, somebody would have to go, oh, and split open an area, because that is the only way that oxygen is going to pass through, is the only way. So think of, all right, maybe it's not water. Let's say I give you all pneumonia. Bacterial pneumonia, goo, thick, green, it's lovely. You're coughing, you're hacking, and what's happening? Where's that goo hanging out?
Around the sac.
In the alveoli sacs, right? So every time you cough, these little sacs are like, they got goo, and then you cough and it goes, and then it settles back down again. That's why we tell people to cough. You're creating a force that actually squeezes, and the sacs go, and it's moving it. So whenever I'm like, okay, I need you to cough, and they go, and I go, okay, great, do it again and again and again. And I tell them, I can't go in and suction that stuff. I can hear it. I put my stethoscope on, I can hear. I can hear it. But I can't go get it, can I? How far can I go? How far can I go? I cannot go into an alveoli. Okay? But where can I go? I can go down your nose or down your throat, and I can get into the trachea. Where can I could hit the carina. I could do it. I have a tube, it's long enough, and I can go down and I can suction right to about here. And that person is gonna go, and they're gonna cough and they're gonna gag. However, if it's here, if the goo is settled here in the alveoli, the only way I'm ever gonna get it is if they go cough, 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 cough. Eventually, give me a loogie. Okay? So there's a certain reality. You need to understand the anatomy and physiology and what happens. So it's filled with goo, so lots of things. So you need to really get the A&P, okay? We'll talk about some A&P, but we can't do everything, okay? I know you guys think I can, but I really can't. So, first off, what's the difference between respiration and ventilation? What did I just tell you respiration was?
The gas exchange.
The act of gas exchange. So it is actually oxygen in and CO2 out. If you don't have that exchange, then you're gonna die. Okay, so if respiration is exchanging oxygen, what do you think ventilation is? The actual act of breathing. Okay, everyone, I want you to stop ventilation. Ready? Go. That is ventilation. Okay, so we talk about ventilation, and this is where it gets confusing. We could put somebody on a ventilator, right? We could intubate them, put a breathing tube down, put them on a machine, and say, you will breathe 40 times a minute. Watch. Push a button, 40 times a minute you are going to breathe. That is ventilation, okay? Does that necessarily mean that you're getting good oxygen? No. I could have no oxygen. I have it disconnected from the wall. I am only ventilating for you, okay? Of course, we usually give oxygen and, you know, other fun stuff. But, so we have to think about when we're in nursing school, what do they teach you to do? To count what?
Respirations.
Respirations. Do you see my annoyance? Okay, because counting respirations, no, I was in nursing school, I was like, okay, right on, okay. Respiratory rate, got it. However, do I really know that you are exchanging oxygen and CO2? I have an assumption. I'm not looking at your alveoli when I'm counting, right? I am literally counting the rate in which you are breathing, which is actually your ventilation, okay? So you don't have to go to your lab and go, well, Drexler said that this is my ventilation rate, because nobody's going to care. Everybody for like, I don't know, since Florence Nightingale, they've been calling it the respiratory rate. But I'm going to tell you that it's wrong, okay? It is ventilation, okay? So don't get confused by, I'm going to count your respiratory rate when I'm telling you respiration is the exchange. It is kind of. You are exchanging, however, there's an assumption, right, that you are actually removing carbon dioxide. And that's why when we start talking about these little problems that we have, you're going to go, oh, that person isn't removing CO2. Or, oh, that person's not getting oxygen. So then is it really their respiratory rate? No. You will come to the dark side with me. You'll see. Hyper and hypo. So what do we know hyper to be?
A lot.
Too much, a lot, excess, right? Hypo, too little, not enough. So we talk about how people breathe. You're not going to say, oh, they are hyper-respirating. And they call it hyper or hypoventilation. So if you were breathing under 6 times a minute, I would say you had hypoventilation. Or when people hyperventilate, we've all heard that term, right? Okay, and you're breathing very, very fast. You have an increased respiratory rate. Okay, so that would be a hyperventilation. And we'll talk more about how does that, what's the big so what about that? If somebody's trying to get rid of excess this or take in more of that, that is a big deal. We're going to talk about how we exchange things versus what is diffused. So exchange is that whole, Maria, I'm gonna give you some oxygen because you're a cell, and you're gonna give me your CO2, which is a waste. That is an exchange, okay? The actual diffusion process would be, you guys are gonna be my alveolar capillary membrane. Okay, so you are in the alveoli. You are the basement membrane of the cells. For me to diffuse, I am oxygen, and I have just come into the lungs. For me to get into the alveolar capillary membrane to get to the blood, because way over there is the blood, I literally have to diffuse across the membrane. So I have to actually hope that the membrane is intact, surfactant's okay, there's not a whole lot of goo in my way, because I have to diffuse across the membrane to get back here to get into the blood. That is actual diffusion, okay? Same thing with carbon dioxide. I'm now in the blood, I'm back here hanging out with the other CO2 peeps, right? And we now need to get back across the membrane, and therefore I have to make sure, hopefully I don't have pulmonary fibrosis, or I don't have cystic fibrosis, where fluid is I'm gonna have fluid problems. Hopefully I don't have pneumonia. So we'll see altered levels in the blood if those things can't get diffused back across. Does that make sense? Okay, so we have, bless you, we have exchange, so she's getting rid of extra oxygen. So far we have respiration versus ventilation, too fast and too little, exchange, and then actual diffusion. No, never mind? Never mind, just wait. Okay. Compliance versus resistance. So these are a couple of terms. Compliance is, what do we think of compliance? Cooperation. You're going to do what you're told, right? You're going to do the job that has been set forth. Okay? So as compliance goes, if I said you all were alveoli and with every breath in, you all went, and then with every breath out, you went, that's we're talking about compliance, right? You are moving as cells as you should, and you are being very good little epithelial cells. Okay? You're being compliant. It's kind of like that stretchy nature of a rubber band. When my rubber band becomes dry and sun rotted, it is no longer compliant. So when I stretch it, it goes pink and it breaks. Okay? Now resistance is kind of, I want you to think of resistance and when we talk about ventilation and diffusion, is what kind of resistance might I need if I'm trying to take a breath in? If I put you in a straitjacket and wrapped your arms like this, what do you think I just did to the compliance of your lungs? Did I increase it or decrease it? Decrease. So I decrease the compliance by increasing the resistance, right? So, what was it? It was a couple months ago. I was watching CSI reruns because I like CSI. And this guy that was a contortionist, they actually like stuck him in a box, and normally that would have been okay, except for it was too long of a period of time. And then there was something, I think it was like it triggered his neurons and he was hypoventilating. So of course I was going, oh my God, decreased compliance, increased resistance, right? Because he was in a box. So he didn't have that. So what else could cause a resistance in your lungs that could make you not breathe as well? Diaphragm. Do you think it's possible to actually nick the diaphragm during any kind of surgery, especially abdominal surgery? And then now your diaphragm, major muscle to help you breathe, now you have problems. What else?
Is someone having like an asthma attack, would that be resistance?
Oh, we're going to talk about asthma. That's a great one. Yes?
So watch it out, like excess mucus in the respiratory tract, and that's resistance.
So it does create a resistance. It's kind of like how we talked about inflammation. And when you get the white blood cells and all of the goo in that one locked in area, how does it get swollen? Well, because there's nowhere else to go, right? So you actually, you're increasing the resistance of something to do its job. So secretions in your lungs. What else? What do you think?
Hypertension.
Oh, okay. So I stab you in the lung. It's not very nice of me, but I do it for a point, right? I stab you, and then your lung deflates. This big open pocket of air goes, and it's now, it doesn't matter how much surfactant you have, I put a hole in there and I released all the air. Where's the air now? In the pleural space, right? So it actually shrunk where it was supposed to be. So now I have increased the resistance. So when I go to take a breath in, air is hopefully going to go here, but air is also going to go where? Out into that pleural space. So I decrease the compliance, I increase the resistance.
I think of like also with, remember like one of the big things they taught like in the medic class I took was the flutter valve. You do a one-way valve if they get stabbed, that way they can still have that vacuum with the diaphragm.
So you could actually release air.
Yeah.
Yeah, that's why you don't just stick your finger in it. You actually do want air to come out.
I'd seen something that said like is it with crucifixion that was they suffocated because they're being sprayed into their chest.
I watched that show too, and that was about compliance. So what did you just like when I said the straitjacket, or you put somebody in a box, put them on the cross. How are those muscles? How are they moving? You are now stretched out. Stand like that for a few minutes and just try to breathe normally. Well, not right now, but try it later. So another thing that we're gonna talk about is about perfusion. So perfusion is actual blood flow. Okay, We're going to talk about perfusion more related specifically to the cardiovascular system. That comes next. But right now, I want you guys to think about perfusion because of the arterial bed that is delivering blood out to the body. It all that blood goes through the lungs, right? So you have a capillary bed that is the alveolar capillary junction. And that capillary bed is very similar to the capillary bed at your toes. And that's where it becomes about perfusion. You have to have an intact capillary bed to get blood flow, to even get the oxygen on the red blood cell to go, here you go, have some oxygen. Here you go, have some oxygen. Without proper perfusion, that doesn't happen. We're going to talk about a VQ ratio, and that is specifically, it's talking about why perfusion is Q. Don't ask me, I didn't make it up. It should be the VP ratio, but it's not. It's a ventilation perfusion ratio. And it's talking about the act of perfusion, so how much blood flow do you have going next to those alveolar beds, versus the actual ability to ventilate. Okay? So it's kind of like if I shut down one thing, the other thing gets affected. If I shut down this other thing, it affects this other thing. Okay, so it's like we're going to look at it as like a in a grid. So the VQ, again, I don't know why it's like a quotient, but however, it's ventilation perfusion. We talk about it like as a mismatch, like when they don't line up, and then it causes problems. Yes.
How do you measure that? How do you define that?
We are going to talk all about that. Seriously. And then we're going to talk even more. I'm just kind of telling you, I'm giving you like the grand overview because we're talking about all of this stuff. And then we're going to put them into, here's an example of this, here's an example of that. So the oxyhemoglobin association and a curve, you can Google oxyhemoglobin, even a disassociation curve. And you will get all kinds of lovely pictures of this curve. And then we're going to go into what does it mean? I have X amount of oxygen available, and I have X amount of oxygen saturated on my red blood cell. So have you guys learned about the oxygen sat probe yet? Okay, your little ET finger, right? You put it on your finger, and what does it measure? It measures oxygen. How accurate do you think it is? It's okay to say not very. And it's stupid. No, I'm just kidding. It's not really stupid. It's one moment in time, though, isn't it? As that red blood cell traveled past the light, it was 100% saturated. Yay! The other 4 that went around where the light wasn't, there was no saturation. So do you think it's possible to be half dead and still be saturated with oxygen? It really is. It's one moment in time. You can leave the thing dangling in the room and it'll say 91%. It's not even on your patient. Your patient's dead. I'm serious. Your room could be very well oxygenated and it's reading air. Okay? So it is one moment in time. It is one literal cell that is going by in an average, okay? So we use it as a tool, but it's not the end-all be-all, okay? How else could I tell if my patient has enough blood supply or oxygenation? Hi, how are you? Mentating, good mentation. She said hi, hello. She's tracking, so what am I saying, neuro? Have oxygen, right? Your hands are kind of warm. What does that tell me? Perfusion?
Yes.
Right? So that means I know her perfusion is adequate. It's getting, and then I can go, hi, cap refill, right? She's warm. So I'm like doing all of those things that I don't even have any tools that I can say, I believe that you have plenty of oxygen. Okay? Like I said, it's one moment in time. So if you put the SAT probe on your patient and it says 100% and they're going, are you going to be concerned or are you going to go, look at my SAT probe says 100%? You're going to be concerned, right? Because somewhere there is a diffusion problem, right? Somewhere something's going on. Okay, so we're going to be talking about all these different principles. Yes?
I was just curious, I guess, for terminology, because you don't have the hypo and hyperventilation. Ventilation is, as you were saying, is breathing. There's also a term related to that, like tachypnea or how is that different, or is that the same?
You're talking about the same thing.
Hyperventilation?
Yeah, respiratory rate is the same as ventilation. Like I said, it's a term that people interchanged or said it wrong hundreds of years ago, and I can't do anything
So
about it.
either one, you're.
So tachypnea is fast breathing. Bradypnea is slow breathing. So it's about the respirations. Someone hyperventilating, if I said you are hyperventilating, that is saying the same thing as you're breathing above the normal rate and you are breathing too fast. So I could say you are tachypnic. Does that make sense? It's just another term.
Okay.
It's like,
Just wanna make
to
sure.
confuse you even more, we added all these other extra terms, and make sure you don't get them wrong. No. But I really want you to understand the distinction, because people will walk up to a ventilator, to a machine, and they'll go, "Oh, is that the respirator?" And you'll go, "Yes, it is. It is, right? Isn't it providing a respiratory rate to the patient? So yes, it is." So it's like potato, right? You know, what do you want to call it? But just know that if someone's calling something else, make sure that we're on the same page. Your patient's tachypnic. Oh, no, they're hyperventilating. Are you going to argue that? No, don't, because you'll look stupid, because it's the same thing, okay? So that's kind of the point. Why don't you guys take a break, and then we're going to talk about this kind of beautiful concept map here. Because I haven't done anything with yours. Yours, when you went and learned, everybody else went exams off, so I was doing it.
Is there an SMA
So I
meeting
have
today?
not adjusted.
Yep. Yes. Okay.
Oh, whatever I said.
Said yes. Okay.
Yeah, so I have to adjust yours, and I still have to adjust Kate's.
Okay.
I haven't done it yet. Okay. So you're gonna have to shoot me. You have to send me an email, and then, because that's the best way for me to remember. Right when I read it, I go straight to my calendar, and then we start, like what day works good for you. Because otherwise I just won't. It depends. Like this, I want to say this Wednesday. I think I do. Yeah, so Wednesday usually right after I have the one, it ends at 9:45. So like 10, 11, 12, and then it's about what I can't remember is when other people put things on my calendar, and then I go, "Oh, great, where did that come from?" And see, like in a couple weeks, I have to take my daughter so I was here on Wednesday right after class, but then I have to get her teeth taken out. So. Yeah, no, your exams other question? No, I think the one you're asking about is what makes her suspect, and it was hyperglycemia. Because hyperglycemia, let's say you've been, if you have a process and you think, okay, this person's now in your office, and
Toothbrush and toothpaste,
and
huh?
their sugar is going to be well over 200. Okay, and so then you think, gosh, Snickers.
So, can you tell me about the bathing thing? Are you like
However, with
naked?
dad,
Okay.
and you kind of
Well, I was like,
then there was another
that's gonna be
question about
interesting.
how would you know?
So whatever you were comfortable
So
with,
it's like, why would you?
I mean, I wore a tag club because
Why would you think you were a type 2 diabetic? Just, I mean,
veins, arms,
would be, I checked your sugar and your sugar was high. kind of guide you through your journey through ventilation and diffusion problems that we're going to talk about, because it's kind of got it laid out. We're going to add some more examples in here, like what is an example of this and what is an example of that. So those exemplars that we are going to use, you could actually add to this, okay? Because this is obviously not an end-all be-all list. But down one side, down your left, we're looking at ventilation. Down your right, we're looking at diffusion. And this is all about what happens when something is not okay with ventilation or diffusion. So we're talking about breathing, or we're talking about oxygen exchange, right? The diffusion process. Okay, so which one do you want to start on, left or right? Left. Okay, let's keep it to the left. Okay, so ventilation, the goal, acquire oxygen. That makes sense, right? When you breathe in, I acquire oxygen, okay? Remove CO2. Whew, yep, totally makes sense. Maintaining the pH level and optimal cell function. So if you guys remember that CO2 is a very potent acid, right? So if in that process of maintaining my acid-base balance, first it's my plasma that helps me, right? Bicarb, hydrogen ion exchange. Then my ventilation system helps me. So if I have high levels of CO2, what do I do? I breathe faster. I hyperventilate, don't I? Or I become tachypnic. I breathe faster, okay? And that is to get rid of the CO2. At the same time, if I have high levels of CO2, it could be that, wow, why do I have high levels of CO2? That's kind of where we go down here. What kind of happens? What happens if I don't get enough oxygen and I have too much CO2? It could be from an obstruction or a restriction of airflow. I'm choking you because you did really bad on my test. Okay, so you're literally suffocating. Can you suffocate from having someone compress on your airway? Pillow therapy? Over the face?
Wait, what? For real?
No, we don't really for real do that. No, we really don't do that. It's not really a therapy.
I was gonna say.
No, but it's a joke. You don't really do that. So what about bronchoconstriction? If I actually had an airway problem, so the gentleman in the back mentioned asthma. We're going to talk specifically about asthma as a problem because it is bronchoconstriction because of inflammation, hypersensitivity, and it's also about the excess mucus that gets produced. So two things with asthma, bronchoconstriction and excessive mucus. But when we're talking about the ventilation side, I got to get the air in and the CO2 out, right? It's about this. So has anybody seen those little sleeping, the sleeping mask or the BiPAP machines is what they call them, CPAP? Okay, so those little machines, sometimes they put them, they're just on the nose and sometimes they're here, and it literally is forcing air. It is literally forcing air in and making the alveoli go with every single breath. So if I somehow neurologically, see, inhibition of neuronal stimulation and mechanisms of breathing. So if something happens and I whack you on the head and you can't take a big breath, you're going to have ventilation problems. If I had maybe a tumor that was growing in my brain and it could actually be causing problems in my respiratory center, causing pressure, could it cause an alteration in my breathing pattern to where I can't get enough air? So like with people that have sleep apnea, they literally have periods of agonal breathing. They don't take that big breath. So sometimes we might do things. What about like with a drug overdose? You have a little too much fun over the weekend, you know, a few pills, some alcohol. If you don't throw up, well, you could throw up and then aspirate, right? That would cause a huge inflammatory response. But people that have had some kind of drug overdose come in breathing like 2 times a minute, 3 times a minute. Not compatible with life. So you have to intubate them and breathe for them. So it's a ventilation problem. Yes?
As far as like the CO2 buildup, I know that like can't over oxygenation do that? For example, if you have a patient that's on O2 and it's cranked up too high, and there's been cases where a lot of times staff or whatever, they think, oh, their O2's down, I'm breathing to crank up the oxygen, but in fact, it can go too high. Can't that cause a CO2 backlog or something, or cause a CO2 to go
So we're going to talk about that. That's like in the family of COPD.
Right, okay.
Yeah, it's a COPD problem where they say too much oxygen decreases the drive to breathe, because people that have COPD have high levels of CO2 in their blood, and that is the mechanism that kind of makes them go, oh, okay, now I need to get rid of some. So by changing that, I'm going to say yes and no.
We had
I'm kind of on the fence on it.
We had a bariatric patient once that had sleep apnea, and he was on CPAP, and overnight on the night shift somehow the adjustments got changed, his oxygen went up, and then when we came in the next day, he was very lethargic and his CO2 levels were really high. We ended up having to intubate him, transfer him out.
So here's here's kind of the theory behind it. If, let's say Kate, for example, because you're sitting up front, because it's okay. So Kate has sleep apnea, and so we know for periods of time she's not going to take a breath. I can give her a bunch of oxygen, right? Now, what does that say to my brain about oxygen? I'm good. I don't need you to breathe any faster. I have plenty of oxygen. So for someone that has sleep apnea and they have high levels of CO2, that's where it says it decreases the drive to breathe. Where thinking, if you sit here and hold your, like, that's why I love kids in the store, I'll hold my breath until I get what I want. I'm like, great, go ahead, you're gonna pass out anyway. And I'll walk over you and leave you in the store. So why do you pass out? It's your body's natural response to, I don't have enough oxygen. What do you do as soon as you hit the floor?
Breathing in.
Start breathing. So high levels of oxygen, it does decrease your brain's thinking about, oh, I don't have enough oxygen, I need to breathe.
So the opposite is you don't breathe, which means you're not expelling enough CO2.
Exactly. So if I go, oh, I'm good, I can just breathe 5 times a minute, because I have plenty of oxygen, then your body is going to be a little confused and it doesn't expel the CO2, and that's why the level. So this is where drug overdose, you not only do you not get enough oxygen, you also don't get rid of enough CO2. Cervical nerve damage. So could you damage the cervical nerves that innervate the diaphragm? I've seen actually somebody come out of surgery and actually they nicked the phrenic nerve, and the person had a hemidiaphragm that was only going. So what does that do for alveoli movement when you need that extra muscle to help with expelling and inflating? So there's different kinds of reasons why you don't ventilate properly. Okay? It's about ventilation, the act of breathing. So you could have blocked or inhibited airflow. So here we're moving down the concept map. Any of those reasons you get blocked or inhibited airflow means no oxygen goes in and no carbon dioxide comes out. So what do I think that does for my pH of my blood? High levels of CO2 in the blood. Acidosis. Do my cells like acidosis? No, just like we just answered about diabetic ketoacidosis. Neurons don't like acid, right? So you start seeing level of conscious changes. Okay, so where does that take us? It takes us to hypoxemia, hypoxia, and hypercapnia. Now let's talk about what do those terms mean. Okay, so hypoxemia is where? Hypoxemia. What's emia? Blood. So not enough oxygen in the blood. Hypoxia, or my cells are hypoxic, is where? At the cell. At the cell. My cells are hypoxic. hypercapnia. It's too much CO2. So it's kind of like the one thing we don't normally have. You could have hypocapnia, but it's not common. You could have too low levels of CO2. How would I have too low levels of CO2 in my blood?
It's not coming out of your.
So if I have a ventilation issue, what would I be doing to reduce the amount of CO2 that is circulating in my blood? Hyperventilating. Do that long enough, you drop the CO2 level, and you change from a normal pH to alkalotic, right? So then how do you fix alkalosis? Slow down the respiratory rate and start retaining the CO2 again. Yeah, so you kind of like, or you pass out, right? Body kicks in. Okay, let's do this normal again. So these three terms, like for example, if I say, how would I know that your cells are hypoxic? How would I know that your cells are hypoxic?
You're gonna look blue.
Okay, decrease function. Okay, perhaps. Can you give me an example? Okay, weak muscles, not getting enough oxygen. Okay. Do you think it's easy to test hypoxia? Do you think it's probably a lot easier to check for hypoxemia? So, kind of boils down to, if you check the levels of oxygen in the blood, it tells you a lot more things. Because you can't go, okay, little neuron, I'm coming for you. I'm going to check your level of oxygen. You can't check in the cell. You just can't. That's why you look at the signs and symptoms of what do I think somebody might be hypoxic. But you can check in the blood. So, I check a PaO2, and it's the partial pressure of oxygen. We're talking about dissolved oxygen in the blood. I check a PaCO2, and this tells me how much CO2 is dissolved in the blood. And we're going to talk about arterial blood gases a little bit more, and which we started talking about, remember, with fluid and electrolytes, an acid-base balance. So here's where we revisit it. So I can look, and I can tell if someone has hypoxemia, because I'm looking at the PaO2, how much oxygen is dissolved in their blood. By that number is how I can indirectly measure what is it in that one little tiny cell. Because if I have low levels of circulating oxygen, I go, well, your big toe is so not going to get oxygen. Who's going to get oxygen if your oxygen's low? Two things. Your brain and your heart. Brain and heart, yeah. Okay, two things. Guts, don't care. Beans, don't care. Toes, don't care. Everything else becomes unimportant except for your brain. So what does that tell you then about signs and symptoms of hypoxia if you are seeing it in the brain? Level of consciousness, right? That tells me, okay, we just made a pretty big leap from my toes weren't getting it to now I'm seeing signs and symptoms in my brain. I'm lethargic. Cyanosis is a late sign. Late. When your lips turn blue, it's bad. Blue is bad. Okay, blue is bad. But when you'll start seeing subtle differences in people, and it's usually pretty subtle. However, if you ignore those things and don't give those people that oxygen that they need, it then gets worse. And then remember, we're trying to figure out at the cell how much blood is available, how much oxygen is available in the blood to be able to get there. So that's how you tie in perfusion, okay? Because it's all got to be transported, right, through the circulatory system, okay? So the PaO2, is going to be really important. We're going to measure hypoxemia. Take a sample. I can measure arterial blood or I can measure venous blood. Because should there be a certain amount of oxygen left over in my venous blood on the return? Oh, yeah, there should. Somebody over here looks like they have a question. You do. Go ahead.
How does your body make sure that the oxygen that you have goes to your blood or to your brain and your heart? Does it increase perfusion for the rest of you?
It's very sneaky. It's about perfusion. So it's kind of like, remember vasoconstriction? When you're cold, you vasoconstrict. When you're warm, you vasodilate. You're increasing blood flow or decreasing it, right? So my body will send signals to my legs, let's say. You guys don't need as much blood. And that's why pulses decrease, cap refill decreases. You see signs of poor perfusion, and what it's actually telling you is the oxygen that is needed is being shunted somewhere else. Okay, so we can tie in, we're going to still keep with ventilation, and then we'll kind of tie it into perfusion later. Okay, so we talked about measuring oxygen in the blood. I can also measure CO2 levels in the blood, right? But can I really measure how much CO2 is stuck in a cell? No, can't measure it in the cell. I make assumptions. So if I have too high of a CO2 level, then I end up with potentially an acidosis. And then my cells really, really don't like it, and then it leads to cell death. Because the assumption is also, if I have too much CO2 and I created an acidotic state, what's going on with the ventilation? Getting the oxygen in is a problem, right? So now I have low levels of O2. So I can say, oh wow, this person's got a PO2 of 50, they're gonna die. We better do something like yesterday, right? When it was 70, okay? So there's certain numbers, there's parameters, and we're not gonna get into all that right now. Bottom line is, what happens when your cells don't get oxygen? They die. What do we go through first? What's the first step? What metabolism? Anaerobic metabolism, right? Your cells, fine, you're not gonna give me oxygen. I'm gonna try for 3 to 5 minutes to say I can function without your stupid oxygen. Fine. What's the byproduct? Lactic acid, okay? Did I just create a more acidotic state? Yes. So without oxygen, your cells have a certain amount of time. So when I talk about somebody fell over dead and they stopped breathing, I can measure that lactic acid because I can say, oh no, they were down for 15 minutes before EMS arrived. They weren't breathing for 15 minutes. I watched that lactic acid level when they actually make it to the hospital, and it's like super, super high. That tells me for a long period of time, anaerobic metabolism was happening, okay? What would their CO2 levels be if they fall over dead and stop breathing? Really, really high. So I have an acid and an acid. What's my pH? 6.28. Right? You could cook French fries in my blood because it's so acidic. Okay? So that's going down the ventilation side. This is all because of you don't breathe right. Literally, respirations. Now, on this side, what if it's a diffusion problem? What if it is the actual exchange of O2 and CO2 at the ACJ, alveolar capillary junction? That's the ACJ. So when I say at the capillary membrane, I'm speaking of between the alveoli and between the capillary membrane that is in the lungs that's about to pick up the oxygenated blood and take it back to the heart, right? Isn't that where it goes? Oxygenated blood goes back into which side of the heart? And then it gets pushed out from the left end. So we learn about this and then we'll move into circulation. So if I had an increased thickness of the membrane, makes it thicker to actually try to diffuse oxygen or CO2, that could cause problems. thickness of my actual membrane. So it would be like where I was just going, yeah, you know, I'm oxygen and I'm just diffusing and I'm going in, you know, to go to the blood. Imagine you guys like 12 thick, the thickness of the membrane. So like, if this was like a fibrotic area, fibrosis, and it was inflamed and swollen, am I gonna get through here? Not very easily, and really things that are kind of passively going in, they're gonna go, oh, I can get through there, okay. So the oxygen's gonna get blown back out, literally, out of the alveoli, because it can't pass through the membrane. So fibrosis, we have cystic fibrosis, and we have pulmonary fibrosis. Asbestos workers have huge problems with fibrosis. Infection, so I have created a thick layer of goo, right? If I'm the outside air and a bacteria got in and lodged itself right in here. Now as oxygen trying to get through this capillary membrane, I might be a little troubled trying to get through the sputum. That stuff's thick, right? I'm not gonna get through there, so I'm gonna circle my way right back out. So as I'm blowing off my CO2, oxygen's going out too. Now here's the interesting part. CO2 actually will diffuse across the membrane much easier. So the CO2 that's out here in the blood will actually diffuse much easier across the membrane to be removed than trying to get oxygen in.
Is that an issue with their structure or pressure or what is that?
Yes, yes, and yes. I think its properties about being diffused in the blood make it easier to cross, I think, from a pressure system. Capillary is a higher pressure to a lower pressure, where when you're breathing in, you're taking a higher atmospheric pressure into a lower pressure system. So without that force, without putting somebody on a ventilator and putting a force and trying to split the C and try to split the goo out of the way or make somebody cough to move that stuff, you will not get oxygen through. Good times. Okay. So when people are like, I can't cough, it hurts. I'm like, well, that's fine. You can die from pneumonia. You don't want to cough? That's cool. Edema. What do you know about edema? Was that enema? So what is it about edema? What do we know? All right, so what do we learned about edema in association with the cells, right? Thinking of like it leaks into the tissues, right? Fluid leaks out of where does it leak from? Vascular space into the surrounding area. So it's leaking out into here, right? Okay, so then you get this puffy kind of swelling. Okay, so could this happen in the lungs?
Mm-hmm.
There's a capillary bed. There's epithelial cells. So you're actually getting fluid trapped in places. It's leaking. Pulmonary edema. So it's like saying all that fluid and all of that blood that has been shifting through. Remember, we have actual air and then we have a blood component. So we actually have oxygen and air and we have fluid with oxygen. So two kind of separate things doing this at the same time. If you have a capillary bed that is a little bit leaky because of an increased pressure, it's going to push that fluid out into that space. So in the alveoli, you could actually have leaky cells, and now fluid is sitting there. Instead of goo, like with infection, it's now fluid. So we see that with congestive heart failure. I can't pump the blood out of my heart effectively, then that is going to start backing up, and it backs up into my lungs. And it's actually about fluid backing up. That oxygenated blood doesn't have anywhere to go because my heart is failing. So you can still oxygenate, but it's just not going to go anywhere. Okay? So we have Decreased usable surface or an increased thickness. Decreased usable surface. So if they're fibrotic, this area over here has undergone fibrotic changes of the epithelial membrane. Guess what? No diffusion happening over here. None whatsoever. That leaves this one side of the alveoli for that one oxygen to try to get through. Because this side, it's too thick, it can't get through. Okay? Decreased partial pressure, decreased solubility. So kind of was mentioning about oxygen being soluble in the blood. That's where we measure it. So when you're measuring with the little ET finger, that is measuring what is attached to a hemoglobin, right? What is transporting. There is amount of oxygen that is actually dissolved in the blood as well that's not being transported, okay? But it's already been released from the hemoglobin, and it's just kind of like hanging out like, hey, I'm oxygen, you guys need anything? Right? The cells, it has to make itself available, so it has to detach. So when that one hemoglobin is cruising by, those guys aren't for right here. They're traveling. Then they will be released. Okay, and we're going to talk more about that too. So high altitude. I don't have as much oxygen up here on Mount Everest. Okay, you have atmospheric pressure issues. You have less actual oxygen available. Causes problems. Hypothermia. Hypothermia can actually kind of be a good thing for you because when you are too cold, your cells start shutting down. But not in a sense of I'm dying, but I'm kind of frozen. I don't really know what you need from me right now. So the metabolic rate actually decreases. So that's why when you pull little Timmy from the lake and you can revive him much easier because he was cold and frozen. You warm him up and his cells start to kind of come back, and they weren't undergoing anaerobic metabolism because they were frozen. They were like, ah. And they didn't need to function because they were so cold. So would you rather be too hot or too cold? You want to be, yeah. I'd rather be a popsicle than be frying, okay? Because what are you doing in heat, extreme heat? Literally burning and damaging tissues with extreme heat. So you always want to go cold. Okay, so hypothermia actually could be a good thing because you reduce the use of oxygen. And we're going to talk actually more about that later. O2 deprivation, well, can happen with sleep apnea. You're not taking in enough oxygen, then you're not getting it diffused into your blood. And so while you sleep, what are your cells doing? Not getting oxygen, right? Anaerobic metabolism. So people with sleep apnea often will, they could end up with learning disabilities. They could end up really tired and exhausted all the time. There was a guy, this is a long time ago, a guy I knew who was a comedian. Big, tall dude, like Samoan wrestler size. He was huge. And I had to go to work, and my boyfriend at the time, they were like all hanging out, you know, playing games, whatever. And I come home in the morning and everybody's like passed out, and here's this big dude, and he's like half asleep on my couch. And by half asleep, I mean like laying up like this. And I'm like, well, I don't know, should I wake everybody up? It's still kind of early, it's like 7:45, and I'm like, I'm just gonna go to bed. And then I'm watching, and I'm like, when's Max gonna take a breath? I mean, and like he finally went, and I was like, Cookie Monster! This is what it sounded like, right? But then he stopped, and he took like one breath, 2 breaths, and then did it again. And then I was like, because I was like, if he does it like one more time after that, I'm going to kick him because he is going to physically get up and have some oxygen. But he always would tell me how poorly he felt. He never felt like he got enough sleep, even if he did go to bed. So then I was like, Max, pumpkin, you have sleep apnea and you need to go talk to somebody about this. I'm talking like almost a minute of not breathing. Like, get up, you're not dying on my couch. It was pretty bad. So there is actually some connection with obesity and height and uvula size and all this kind of crazy stuff. Have you had your tonsils removed or not? And then I'll hear about all this, and then I'll see somebody that is short and thin that has sleep apnea. So I'm like, I don't know. I don't know. So, if you have blocked transfer of oxygen and it can't get in, or you can't get your CO2 out, we're talking about diffusion problems, right? It is a diffusion problem. Oxygen and CO2 are a diffusion problem. Ventilation is the act of actually getting the oxygen and CO2 in and out. But that's just in and out to the alveoli, not in and out into the blood. So kind of think of diffusion to blood and ventilation just actually getting it into the body, okay? So as we talk about COPD, emphysema, acute respiratory distress syndrome, asthma, when we talk about these things, you can actually kind of plug them in. Where's the problem? And then ultimately, you kind of end up the same place. The hypoxia, hypoxemia, the hypercapnia, okay? Those all end up the same way. So, what's hypercapnia?
High level of CO2.
And hypoxia is what? At the cell. Think cell. Hypoxemia is where? In the blood. Okay.
Thanks, buddy. Oh, you're welcome. Yeah.
So can you guys review the respiratory structures and stuff on your own? Like, remember where are your lungs? Okay? That would really help me, thanks.
Oh.